taking time for your health. The African American Wellness Watch. Trusted information for us, by us. Dr. Mike LeNoir and other experts from around the country and around the world have the latest on how you and your family can get healthy and stay well. It's time for the African American Wellness Watch. A famous philosopher once said, if you don't know your history, then you're doomed to repeat it. Well, the Wellness Watch takes that admonition really quite seriously. So all this month, Black History Month, we will focus on health disparities that affect African Americans in a unique way. We will look to their historical underpinnings in hopes of finding strategies to address and eventually eliminate health disparities. And we're honored to have world experts to help us on this. First is Samantha Artiga. She's the vice president for KFF, which used to be known as the Kaiser Family Foundation, and that's the nation's premier independent source for health policy. Ms. Artiga is the author of a recent paper on the historical roots of health disparities. Ms. Artiga, thank you very much for joining us.
Thank you.
And of course, we have our host, Dr. Mike LeNoir, who through his 40-plus years of practice has fought to overcome health disparities that he's seen in almost every day, both personally and professionally. Mike, welcome to the program.
Thank you.
I guess the first way to start for both of you is that let's talk about the health disparities in general. What are the 5 or 6 most disparate things that you find in the healthcare system as it affects Blacks? I know that there's been some concern about the amount of pain medication that African Americans get versus the amount of pain medication that whites get. So what about that, and what about the other ones?
Yeah, so I can jump off here. Every year we at KFF conduct an analysis looking at how experiences with healthcare and health vary by race and ethnicity. And what we see is a really consistent pattern with Black people faring worse than white people across many measures. These include measures of health access and utilization, so higher uninsured rates, going out without care due to cost, but we also see it in terms of health outcomes. So shorter life expectancy, widening life expectancy gaps in recent years post-COVID, worse self-reported health status, higher rates of infant mortality and pregnancy-related mortality, and higher rates of chronic diseases like diabetes and asthma. And we also see it in terms of different experiences within the healthcare system. So higher rates of unfair treatment by providers due to race and ethnicity, as well as more reported negative experiences. So things like being refused pain medication that patients thought they needed, or having direct questions or requests ignored.
Yeah, well, my experience is very, very similar. One of the things that is often missed, however, is the fact that so many of these chronic conditions are not genetic and don't have as much to do with access or insurance or opportunity. For instance, right now, it may be easier for me in the practice that I have to get services for Medi-Cal patients than I can get for third-party patients. So nobody's happy with the system. But if you look at a number of studies across the board, especially in prostate cancer, you start African Americans in the VA with exactly the same diagnostics, exactly the same management. They actually do better with prostate cancer than their white counterparts in those studies. So there's a lot inside the system. And we used to focus a lot on wellness at the African American Wellness, and we do. But we didn't start like that. We started because we did not, as a doctor, I did not like the way African Americans were treated differently. And I was convinced, and I'm even more convinced today, that it's how the system looks at African Americans, treats them, and evaluates them that is as much the problem as some of the other more traditionally call for social determinants of health.
And what are some of the historical underpinnings to all of this? This didn't just sort of happen in the last 20 years.
Yeah, so when we look at these patterns, what we really are seeing are the impacts of racism and discrimination and the roots of historic beliefs and policies. So today we know race is a social construct and there are no biologic differences by race. But when we look back to the past, we see that there were since now disproven beliefs of biologic differences. and attitudes towards white supremacy that led to false ideas. For example, believing that Black people felt less pain than white people. And that really contributed to a series of abuses and mistreatment of Black people within the medical system. We can look back and see instances of medical experimentation on enslaved Black women to develop new surgical techniques, forced sterilization of low-income women of color, and of course, the infamous U.S. Public Health Service untreated syphilis study at Tuskegee. And so all of those abuses and mistreatments are rooted in these now disproven beliefs, which unfortunately continue to permeate within the healthcare system in many ways today.
You know, we considered something called the slave health deficit. Racism has been a problem since we were brought to this country 400 years ago, and we never caught up. It's funny how the impression of African Americans sticks regardless of decade, regardless of all of the attempts to bring us together in a health equity situation. So we look at that as a 400-year problem, and a problem that really substantially has not changed. The view of African Americans in this country is always disparate and contributes to poor outcomes because of that.
You know, there's one thing that continues to baffle me about this whole thing. The medical profession has been slow to admit, if you will, that there is a problem with themselves. That just because you put on a white coat doesn't all of a sudden mean that whatever the tropes that you were brought up to believe have all of a sudden disappeared. So it would seem to me that the medical profession, if they wanted to begin to address this, that it would start sort of at a very basic level in medical school, but that doesn't seem to be happening, right?
Well, I think what we see is that there are some efforts within the medical profession to reckon with some of these past beliefs and their impacts. But at the same time, race continues to permeate a lot of medical education and clinical decision-making in ways that perpetuate disparities. So the ways medical education may still contribute to racial stereotypes, disease stereotypes, nomenclature for certain diseases, as well as having inherent biases remain among medical students. There also are issues associated with some of the clinical treatment guidelines, and in particular algorithms that use race as a factor. And I think there are growing efforts to re-examine the use of race in some of those guidelines and algorithms. But if we look at the experience to date, those have led to exacerbating disparities in some cases. I think probably the most well-known of that is the use of different measures for Black patients in terms of testing kidney function. And we're now seeing some institutions begin to root out and eliminate the practice of using race again, because we know there are no biologic differences by race. And when we're seeing differences by race, it's often just a representation of the impact of racism.
You know, I was one of the 13 authors on the paper to say that race still needs to be a construct. And we published this in the New England Journal in January of last year. Because if you look at the concept, we probably did ourselves in many ways, because we did the classic study on African Americans and genetics, looking at some both social determinants and genetic determinants. And it's difficult to tell when you look at an African American, what part of him is African American, what part is Indian, what part is African, and what part is Caucasian. So that does create an issue for pure clinical research. But here's my problem with that. I'm African American, and if I'm African American and I go into the healthcare system, I don't get treated the same. I don't get looked at the same. I'm not involved in the clinical studies as much. And so consequently, as long as I'm in a category that's at risk, I don't care what the scientific community says, I'm going to be concerned when they talk about what happens to African Americans with various diseases. You're right about the glomerular filtration study, in which they demonstrated that over years we've used these two sets of data to determine who gets a kidney, and finding out that African Americans the same filtration rates was a problem. But the question I've always had of the scientific community is, well, why am I dying of asthma? Well, why am I? Because I'm black. Why am I dying of hypertension? Because I'm black. Why am I dying of cancer prematurely? Why am I not going to get the same diagnostic studies? Simply because society determines I'm black. And so that's where I have a problem, having done pure clinical research and research on the social determinants of health. I think there's no way in the world I'm going to ignore a study that says black people have this or that, and I need to do that or this. It's just not going to happen. And so we're going to fight that.
What about this new use of AI? Is that a step forward, or is that a step backwards, or a step to the side?
Well, you know, the garbage in, garbage out. If you look at the computer, if you look at the studies that have been done, there are lots of studies suggest that AI has a very negative impression of black people. And I think a lot of the data that they get comes from the criminal justice system and other systems. And so consequently, there's an interesting article that I read this month that talks about artificial intelligence. And if we don't make certain that we get the right information in, artificial intelligence may not be kind to people of color.
Yeah, I agree 100%. The impacts of AI are going to depend on what it's built on. And so whether the data that are being used to build it have biases built into it, whether the data are representative of diverse experiences. And to the extent that the underlying data have biases or are not representative, then the use of AI may contribute to widening disparities going forward.
So we've only got a few minutes left, and what I'd like to if we can come full circle, and ask, what does the research and what does the look back at the historical underpinnings of racism, does any of that suggest effective ways forward out of this morass that we've been talking about for the last few minutes?
Well, I think one thing is just squarely recognizing and addressing the fact that that much of what is driving these disparities is racism at multiple levels and in multiple forms. So in our structures, in our systems, in our policies, as well as in our interpersonal interactions. Again, carefully examining how race is being used in medical education and in clinical decision-making, particularly as new tools are being built to guide that decision-making process, and examining if race is being used in a way that may perpetuate disparities or potentially mitigate them. I think there is opportunity with some of these algorithms to take out some of the bias that's built into the system, but it needs to be done carefully and intentionally. And I think also a real focus on continuing to diversify the healthcare workforce so that more people have the opportunity to get healthcare from people that have a shared background and experience as them. We know that Black physicians remain underrepresented in the healthcare workforce. And we also know that what your provider looks like makes a difference, and that people who get more care from providers who share their racial and ethnic background report more positive interactions with their provider. And there's also some research pointing to improved health outcomes.
I'm very pessimistic about the ability to make these changes, because the society is not ready to make these changes. If you look at it politically, if you look at the divisions in this country, I don't see us giving much more credibility to the fact that being Black is somehow different in the healthcare system. The recent Supreme Court decision on affirmative action will effectively wipe out a lot of the programs that were designed to take advantage of the information that we just talked about.
Despite that pessimism, one thing we do have is more information to help our audience to navigate the healthcare system, despite the hurdles that we've been talking about, present and past. Information on the KFF website and information on our own website as well, aawellnessproject.org. Remember, this is the first in a series that we will be running all this month on health disparities and their historical roots. Mike? As I said before, we're out of time. I want to thank you both for coming. This is a good way to sort of begin Black History Month. Not all of the news is terrific, but I think at the end of the day, at least now there is information that people can use so that they can get over an awful lot of the issues that they face as they try to deal with the healthcare system. So, Ms. Artiga, thank you very much, and Dr. LeNoir, why don't you take us home?
Yeah, I'd like to thank Ms. Artiga and the Kaiser Family Foundation. I read that report pretty much every day. It's a good thing you got the little ones first, and then you have to get involved with the big ones. But I get more information from that, and I look at a lot of these newsletters. I get more information from the Kaiser Family Foundation report every morning. So to thank you for that. And I'd like to thank you, George, for putting this program together to jump off on Black History Month. Not always a celebration in regard to health, but certainly a necessary program. And I'd like to thank those of you who are taking the time to look at our program to remember that health is your biggest asset, so protect it.